the matter with him? He's alright. I see his face. How do you know? He's alright.
And I worked nights, basically the evening shift from 3 to 11 every day in the medical records department.
So time out for all of our young physicians. So medical records were actually in the analog universe, pieces of paper, folders, charts, paper clips. And working in medical records is a test of stamina and endurance and abuse. Hello, and welcome to the Fire Chief Podcast, the only podcast dedicated to the Chief Medical Officer. I'm your host, Lee Scheinbart, and this podcast features stories and wisdom from the best Chief Medical Officers in healthcare. Today, our guest is Dr. Robert Bob Underwood, the Chief Medical Officer of San Juan Regional Medical Center in Farmington, New Mexico, which for those of you who do not know, that is located near the Four Corners of the United States. Dr. Underwood was born in Frankfurt, Germany, into a military family, which means that he ultimately grew up in several different locations, but then he was fortunate enough to earn an appointment and an invitation to attend the United States Military Academy at West Point, New York, where he earned his undergraduate degree. He went on to earn his medical degree at the University of South Carolina in Columbia before entering residency in emergency medicine at Wake Forest University School of Medicine in Winston-Salem, North Carolina. Dr. Underwood also has earned a Master of Healthcare Delivery Science from Dartmouth College in New Hampshire. And as you will hear in a moment, Dr. Underwood has the right voice for radio and podcasting and has done both. So we are really happy that he has accepted the invitation to be on this podcast. And he is the author of The Leader's Compass for Medical Professionals, modeling personal values to influence people, accomplish the mission, and improve the organization. I have a copy of it right here in my hands. Bob, welcome to the show.
Thanks, Lee. It's good to be on.
So we were chatting before the show, and you are the president-elect of something in New Mexico. Tell me a little bit about that.
Sure. Yeah, I am the president-elect for the New Mexico Medical Society, which is, of course, is the kind of state chapter, if you will, for the American Medical Association. And of course, our state session started day before yesterday. So we're in the process of reviewing documents or proposals, the bills that are being brought before our House within the state legislature. We call it the roundhouse here because of the shape of the building. But so I will be there next week. We'll have our white coat day. So exciting stuff. Never thought I would do it. It's you and I were talking about how sometimes things come up. You didn't really think that you would ever be doing that. This is one of those for me. So it's been pretty exciting learning how to read bills and mark through them and also how to appeal to my local legislators that in hope that they'll support healthcare.
I think that's wonderful, and more physicians should consider the opportunity afforded to them to work with local and state legislators. That is how some changes will occur in the near term. There are no other obvious sweeping policies unless they start locally.
That's absolutely true. And the other thing that I have found is, especially as a CMO, the complexity of healthcare, the financing and how it works is not obvious. That your legislators, your representatives will assume that it exchanges money like any other business does. And nothing could be farther from the truth in terms of healthcare. And so your role to be able to help educate your legislators on how it actually works in a healthcare environment is really important, because otherwise they just don't know. And if they don't know, then they can't consider legislation that will affect that in the appropriate scope.
I fundamentally and wholeheartedly agree. I had the privilege and honor of being somewhat of a lobbyist in Washington, D.C. early in my career. And regardless of what people think about lobbying, it is part of our process. And it is how policies get made, because as you allude to, the experts can reach into those details and highlight for our legislators, for our elected officials, the importance of something that they just don't have the expertise.
Right.
This is not a criticism of the legislative. They need us to help them represent us in the role that they have at the Capitol. So
absolutely true. Yeah.
All right. Well, we need to back up just a second now, Bob, and we need to establish a couple of housekeeping items before we get into the meat of this. So I first have to say I am sorry that Army lost to Navy in the recent Army-Navy football game in D.C. I was there. It was a fantastic game. I'm a Navy guy by extension. It was incredible. But so maybe I'm really not that sorry. But as a cadet, I imagine you attended the rivalry back in the day.
Oh, yeah. I've been to the Army-Navy game quite a number of times. I went once before I went to the academy, and, of course, required 4 years at the academy. That is one of the games we like to say, cordially required to attend for mandatory fun. But it was fun. It's very exciting, and I've been a couple of times since graduating as well, and it is quite an event.
I believe in my own heart that it is the purest high-level collegiate football game we have, not D2 and other great college games, but at a D1 level where almost exclusively, going back decades, these young men do not go on to the NFL or other athletic endeavors. They spend the next 5 years in service, and that they know that, and everybody around them knows that. So it is truly a collegiate event.
Yes, absolutely true. And you're right. They are dedicated to the game, to their schools, to the cause, if you will. I mean, every one of them understands that the Army-Navy game is being watched by veterans and by active service members literally all over the world. It's important to them.
Well, to that end, we both have a mutual friend by the name of Mark, also a proud graduate and a veteran, retired from the service, who shared with me recently that only about 25% of the academy graduates go on into the military beyond their 5 years of service, their compulsory service. And that part of the rationale here is that the academies, all of our academies, serve not just our armed forces, but serve to create leaders in all sorts of industries like manufacturing, aerospace, law, and in your case, healthcare. And so to the point that they play the game that teaches them leadership lessons, life lessons, and they go on and live in spaces outside of the military. And you're a seasoned physician leader in a very remote location, serving your surrounding community. So tell us. So let's begin. Tell us how you went from South Carolina to the role of chief medical officer. Give us your journey.
I came out of the military. I was a field artillery officer initially, so didn't have anything to do with medicine. And through a number of factors, I initially served my active duty time, went to work actually for Caterpillar Tractor, did operations management with Caterpillar Tractor in industry. And then Desert Storm started. I got called back on active duty during that time frame. And while I was there, my spouse's job moved her to South Carolina. So when I finished my active duty time, I moved from Chicago, basically, by way of Fort Hood, Texas, and military to South Carolina. And I said I would find something to do when I got there. And so that something to do was medical school. But I didn't really have any background in medicine or working in medicine. And so I went by the med school in South Carolina and said, okay, here are my transcripts from the academy. Am I stupid for even thinking about this? And they gave me some pointers. And so, of course, I had to go back and get my pre-med classes. So I enrolled and got biology, organic chemistry, the things that a general mechanical engineer isn't going to get in their studies. And then I worked nights basically the evening shift from 3 to 11 every day in the medical records department. And so I did that.
So time out for all of our young physicians.
Oh yeah, medical records.
Right. So medical records were actually in the analog universe, pieces of paper, folders, charts, paper clips. And working in medical records is a test of stamina and endurance and abuse. So my hat is off to you on that one.
So I was the evening shift supervisor for the medical records department. And yes, we had a file room that was about the size of a basketball court that was nothing but paper charts. So, yeah.
And again, for our young audience, so as an intern, maybe you kicked it to the fourth year or the third year medical student, you get that late night call for an admission and somebody tells you to go down to the file room and get that chart. And good luck to you. Good luck getting it. Good luck getting back in time before somebody might have a choice word or two about it.
Indeed. Yeah, that's very true. And what's also interesting is I can remember at the time we were just getting things on computers, like lab results would come back on a computer, and a word processor was used to do the discharge summary or the H&P. And I remember thinking, the person who puts all this together into one unified platform, they're going to have it made. And I still went on to become a doctor. So
yeah. Keep going and tell us how you got to the chief medical officer.
So I went to med school there in Columbia. That's where I was working. And so that by then I had 2 kids, and so I wasn't interested in moving. So once I was accepted there, I canceled all my other interviews. Then I did my residency at Wake Forest, like we said, up in North Carolina. It was a great residency program, one of the first emergency medicine programs that were established. And then I practiced in the Shenandoah Valley of Virginia for quite a while. In that time, coming back to medical records now, my CMO, basically the person who had my job at that hospital, knew what my background was coming from the military, because he too was actually a retired Army colonel, doctor. And so he asked me if I would be interested. We were trying to implement an EMR. Now, this was really early. It was just transforming things over onto the computer-based platform away from paper. This was not order entry or any of that stuff yet. But it was failing miserably, and part of it was because physicians weren't involved in the process.
Right.
So he asked me if I would be interested in doing something that they were calling the CMIO. And so what I like to say for people who end up doing administrative work in healthcare is if you do one project and it goes well, they will give you 2. We will give you 2. And if you come to us and you did 2 of those projects well, we're going to give you 4. And it'll keep doubling until you hit your limit, and then it becomes a full-time job. And so that's kind of how it happened. I did the CMIO stuff. Then I was in my graduate school. We were looking at population health management. We were looking at ACOs. And so we were looking at clinically integrated networks there in the Shenandoah Valley of Virginia. So I ended up heading up our building of that process in the Shenandoah Valley. So there was a lot of things that were happening. Now, how did I end up back out west? So my family is all from Colorado. So I was looking to come out here, but we were an independent hospital initially, and then we were acquired, merged with, choose your words, with a larger hospital system from being an independent, which meant that almost all of the stuff that I was working on moved to corporate. And when it moved to corporate, then that really kind of eliminated my administrative role. I was still working in the emergency department at the time, so doing a little bit of both. We talked about what roles I could fulfill there, but it was kind of piecemeal. It was like a little bit of this, a little bit of that, and by then I had my master's degree. I had all of this experience, and I said, you know what? That's great. My kids are all grown up. They're out of the house. I'm going to go look for something that's more full-time and tacked on to like a real CMO role. So I moved from there out to Colorado. I was in a hospital in Pueblo, Colorado, which is where my family is from, going back about a century. And I was there for a couple of years, but it was also part of a big corporate system, and it went through a rearrangement as well. And so I took that opportunity to come back to the kind of hospital I'm at now in San Juan Regional, in that it is an independent hospital with an independent mission. We're not part of a big hospital system. And that's kind of what I was looking for. Not that I have anything against necessarily the bigger systems, but it gives you more in your decision-making capabilities. We talk about strategy. We talk about market. We talk about what service lines are going to be of need to our particular community and our particular population. And we're self-determined in terms of the finances of the organization, strategy of the organization, how we want to approach multiple facets. When you work in one of those bigger systems, unless you're at the corporate level, you're not part of that decision-making process. And so this is something that I was really kind of looking for. I enjoy being in that capacity, and I feel I have a lot more influence over the organization and a lot more over the physicians within our organization as well.
Thank you for sharing. That's a fantastic background. And two elements that I want to highlight before we get to the next question for our audience is so traditionally, like there are analog medical records that exist in our memory, it is also a tradition in healthcare, at least in my opinion, that many of us get tapped on the shoulder to take on a project to reduce some friction in the emergency department or transmission of laboratory information. And as you say, you start to find that you're into it and other people are into the fact that you're doing well, and you get more and more responsibility until it becomes a full-time job. What I do think is important going forward, given the speed and the pace of the universe of the House of Medicine, is to think more intentional earlier in your career and to begin to go for opportunities and go for projects and bring value instead of waiting for somebody to tap you on the shoulder. And the other point, as you state, is because things consistently are changing, be adaptable and agile. Say, yeah, I don't have any heartburn about the corporate structure, but I don't want to work in it. I want to be in an independent facility, clinic, federally qualified health center. So many other opportunities that
Huge.
Are what I call our students of leadership need to consider and be intentional and keep following where you want to be to set yourself up. So,
yeah, I think that that's absolutely correct. And, one of the pieces that I left out in part of my conversation is that in that process, I was diagnosed with multiple sclerosis. And so that played into some of my decision-making about actually becoming the CMIO and deciding to pursue a master's degree, because with MS, you do not know the progression of the disease. And so I had to weigh whether or not I was going to be an effective emergency physician long-term career. And so part of that was weighing alternatives as well. Knowing that I had this background, knowing that, and we talked about it before a little bit, but really the purpose of the military academy is to educate leaders, to build leaders. And I knew that I had that background. And so to take these opportunities that were available, to be intentional about seeking out, okay, how do I build my knowledge base so that I understand healthcare, how it works, the inner workings behind the scenes. What are all the other roles on a senior leadership team, and how do I work with them? What are the roles that I'll have to interact with outside of the organization as well? These are all things that you learn kind of in your master's program and also by experience. But then it became very intentional. How am I setting myself to be in that next level so that I can progress? And people would ask me, well, what are you going to do with that degree? And a lot of it was, I don't know exactly what it's going to do, but it will open doors for me and it will create opportunities for me to advance.
Yes,
and it has.
Yes. And so that leads us nicely to our next question. So you have this journey, you have clinical experience, you have managerial experience, informatics, people, etc. If I were to come to Farmington and hang out with your coworkers, and I were to ask them, so tell me about Dr. Underwood, what do you think they would say? What do they observe about you, and can you reflect on that?
Yeah, and I've thought about this, and I think it depends on who you ask and where they are in terms of my interaction. So I have several people that report to me directly or indirectly. I would hope and I believe that their position would be I'm a listener, I'm open-minded, I'm approachable, I consider a big picture, that if I don't, a lot of them come to me, they're leaders in and of themselves. Like the people that report directly to me are also leaders. They have their own teams. And so they appreciate that if they are coming to me, they're asking for something because they have hit a barrier. They are trying to accomplish something in their own leadership role that has been unsuccessful. And so they don't come to me with the easy stuff. They've already solved that. So when they do come to me, if I tell them no, or I give them an answer that's different from where they were kind of coming from, that I explain the process, or I explain the rationale, or a piece of the variable in the picture that they didn't know before, and they greatly appreciate that. That's what I hope they would say. But, you'd have to talk to them to really kind of weigh that in.
The next time I'm in New Mexico, which is frequent enough, that I will commit, as I've stated the last time we talked, I've got to get up to Farmington and hang out up there.
Now, those are the people that I lead. I would say that the other people on the senior leadership team who I work with, I would hope that they would say that I provide a rational input to the decision-making process, that I listen to their position, but I also strongly support. Most of the things that I look at is, how will it affect the clinical care? How does it affect physicians in performing those duties? And the most important is, how does it impact the quality that we are providing as an organization to our patients? How are we maintaining access to care for our patients? Because that's really the position, and I think the primary role that I need to bring to the table. There are finance experts at the table. There are operations experts at the table. There are IT experts at the table at the senior leadership level. There are HR experts. I am the expert on medicine.
Physician leaders are undervalued and undersold in a couple of ways, and you brought them up, and I'm going to expand the thinking. Yep. So and this is not taught to us in medical school or residency, and it comes with time in the role that you're in, or the CMIO role. The people that report to you, you must help them manage those barriers and those obstacles. That is your number one priority, other than developing them, coaching them, mentoring them, which I believe you do naturally, whether you know it or not. The second is to help them achieve the things that they need to, because only you can solve that barrier. Only you can break down that obstacle through influence or authority, what have you.
Right.
Physicians in their clinical training, we just plow through those barriers. So I need a CT scan. I need an MRI. Go to the lab. I need this done. I need that done. And we bark out orders, and people do these things because we're trying to affect the immediate care of the person in front of us. So when people come to us as clinicians, we're kind of barking orders back at them, as opposed to, well, what exactly are you saying? Well, Mrs. Jones is in the waiting room. She's very upset. Just bring her back, right? Instead of that MA is upset. He or she hasn't told you why they're upset, because there's barriers out at the front desk. And, good independent clinicians who have their own practices know exactly what I'm talking about. Many of them do not. So that's item number one. And item number two, when you're talking about your C-suite peers and or the board that you're leading up. So you're leading down by helping people and eliminating barriers and obstacles. And you're leading up by what are they thinking about? What's important to them? Right. I have to present it at their level. And maybe if I'm lucky enough, they'll help reduce a barrier that I'm experiencing. Right. And again, physicians we are trained as apprentices in our third year and our fourth year to tell the intern tells the resident goes to the chief resident. We're pretty good about elevating communication, but we're not good about thinking, what is the attending thinking? Because we're thinking like, I got to present it right. I'm scared to death. I don't want to make a mistake. But the attending is thinking about the patient and
Right.
your education, right? So I think you have made a case for why experience and leadership is, again, something that is an achievable and learnable skill. And you have the background at West Point and in other roles, but I think we can continue to help our younger colleagues understand these new skills to become an intentional leader.
Yeah, I think the communication style that you use in a leadership role, and so I break apart, and it's even in the book, the difference between management and leadership. And so leadership being, I won't say the key, but let's talk about leadership in terms of how you influence other people. And that is a learned skill, and it is something that is not, it isn't intuitively obvious, especially from what you said for clinicians. In fact, a lot of the things that we learned and how to get things accomplished, they may work when you're writing orders and you're taking care of a patient. But if you're asked to lead a big project or to be part of a problem-solving or process improvement initiatives, those don't work.
Okay.
You have to understand where other people are coming from. That's one of the reasons why, and you talked about Mark Hertling earlier, and he believes as well that physicians who are in leadership training ought to do it with people who aren't physicians, because that way you're learning what are the barriers that they're running into, what are the influences that are pushing on them that aren't clinicians to try to get other things done. And that is a very different pathway than taking care of a patient. So yes, I think that those are really, really important. I think it's important to learn it theoretically on how it ought to work. But unlike medicine, in terms of writing orders and providing medications, doing certain studies, it is very much more skill-based. And so you will learn about something. The adult learning cycle is you learn about a theory, you try to think about how it would apply in my life, you try to do it, you fail miserably, and then you reapply it and think, okay, what could I have done different? And then you go through the cycle. And so I think that it's important that you iterate that cycle in terms of your own leadership development over and over and over again. And it will teach you, but be conscientious about, okay, what could I have done better in terms of my leadership role to get the outcome that we were really looking for? Now, whether it was buy-in or whether it was actually developing a new product, a new workflow, you need to think about how you could have done that better. Now, that's leadership. Management is also really important. You can't run a healthcare system without management. Management is about getting the right people, the right things, the right amount of time, the right amount of money into the right places in order to be able to get the outcome that you need. And you have to understand both of those to be an effective clinical leader as you move through that process.
I can synthesize that from a phrase I learned in my leadership development, right? Leadership without management is delusional, and management without leadership is stagnation.
Yeah.
So you and I clearly see alike on a lot of this. I think that in addition, leadership is always a marathon, and one of the requirements is to always remain curious and be willing to constantly look in the mirror. If you think you know it all, you're probably going to find yourself exited from your role.
Yeah, absolutely. And so I look at it in two. One of the things that I say is curious and compassionate. And the compassionate part is trying earnestly to understand your team and understand that they too have pressures that they are responding to that you may be unaware of. Could be at work, could be at home, all of those things. So curious and compassionate, I think, are huge pieces of being effective as a leader.
So let's pivot a little bit. So we've talked about your leadership journey, some of the skills and requirements of leadership, management, etc. So with all of that in your toolbox, what is perhaps one of the hardest things you have faced as a chief medical officer, aside from COVID-19? Because many of us have already been through that. We don't need to resurrect that today. So tell me, are there any other events that you wish to discuss?
So physicians are incredibly accomplished. They have been challenged and they are resilient and they have gotten to where they are because of incredibly hard work and dedication. And I think you and I have talked about this before, that physicians often don't see this difference that you and I have been talking about between the skill set they developed in order to be successful doctors and a little bit of a different skill set to be an effective leader. And so to work with physicians to help develop them as a leader, sometimes they don't see the point in going through that additional training in order to be effective as a leader. And I think that it is important to work on that skill set, to put yourself in positions and to learn both the theory and the practical application of leadership. I think that's a big deal.
You're the first guest on our show to articulate something that I think we need to explore. Why do you think that physicians, and we're generalizing here, we're simply generalizing.
Completely generalization.
Why do you think that they are reluctant and or resistant to the notion of learning about leadership to be effective? What's behind that in your mind?
I'm not 100% sure, and I think it's different for every person. I think that some of it is that I'm already successful. I'm already doing great things. And this other stuff feels fuzzy. We're scientific based in terms of being clinicians. And a lot of the theory behind understanding leadership and how you interact with other people and how you motivate other people is not as clear as you do this. The patient has this kind of infection. You provide them with a first-generation cephalosporin that will effectively treat these particular types of infections. You do that, sure enough, that's the outcome that you get. It's not nearly as clear-cut. And so it feels fuzzy for those of us that have been scientific-based our whole lives. And so I think that that's part of it. The other is we do lead as physicians, but we lead in a different way. One of the examples that I give when I teach leadership is I'm an emergency physician. I have run quite a number of codes over the course of my life. And so many times when I'm running a code, I'm watching, I'm observing, I'm making sure that things are being done, but I have a highly skilled team who's helping me in this code or who's doing the code with me, and they don't need a lot of prompting. Every once in a while, I'll have somebody new. They may need a little bit more prompting than someone else, and it's incredibly time sensitive. And so that's one style of leadership that I would apply there. I have also implemented CPOE in a hospital that was a multi-month or even year process with other physicians, with nurses, with IT people that were all part of my team. And my leadership style had to be adapted so that I got an effective outcome, a good, strong working team that was cohesive and bought into what we were trying to do. But my leadership style was very different than what I would do running a code. So it's a leadership's responsibility, the leader, to say, what is my task? What are the circumstances around the task that I have to do? Time, stress, knowledge base of my team. How much do they need to be developed? And how do I adapt my leadership style so that I'm accommodating for the task and the team what I'm trying to get accomplished. So my point is that I don't know that physicians always see the need for that differentiation depending on what they're trying to accomplish. And that's why it feels fuzzy.
Yeah. So in my mind, you are uniquely suited because you forgetting that you were from a military family and traveled the world and ended up at West Point. But then you can't forget that because your experience is you come from a certain background. That's why I always ask my guests where they come from, try to understand them, try to understand their motivations. And you were trained as a leader and you studied as an engineer and you got into informatics. So you're unique in that you may not be like the average physician that you are sitting down with, having a cup of coffee with. They're smart, they're capable, they're competent, they're highly accomplished. However,
Usually.
they may have come from a different spot in the universe and their motivations may be highly aspirational. The currency that drives them every morning is, I'm going to save a life. I'm going to diagnose this amazing condition. I'm going to put somebody back together again, et cetera, et cetera. And their wiring and your wiring may be off just enough that you bring a fresh perspective that they don't have, but they have a different perspective than you. And where I'm going with this is while all physicians are absolutely leaders, whether they know it or not, whether they like it or not, they don't necessarily want to go into leadership. And this was the question I was getting. So why don't they do that? Because it's not their currency of motivation. And then we have to, as leaders, okay, I get it. This is all you want to do, and I will break down those barriers and reduce those obstacles so you can do exactly what you want to do. In return, let me be the leader.
Right.
And there's a little quid pro quo there.
Yeah, I think that's key. And going back to the physician component of it, they are incredibly talented, the physicians that are in a number of those roles. We recently at our organization went through a formalization of a lot of our medical directorships, actually building tasks behind them. Here are the expectations if you're going to be in that leadership role. And we also, and I think that this is important, to perceive yourself as a leader of others. And when we work in the clinical realm, I work parallel to my partners, but not necessarily with them or lead them. And you have to have a little bit of a difference in mindset when you move into that role.
Absolutely.
And so formalizing that, I think, is part of it. But then we also, and the physicians at my organization, we have quite a number of caregivers. But if there are, I won't say problems, but if there are efforts that we're working on in any particular department, we now go to that department chair, that department medical director, and say, hey, these are the things I need you to help me try to accomplish. And that helps develop them. That's right. For whatever that next level of leadership is going to be for them. Remember, right. we said it was understand the theory behind the leadership, but you also got to put it into practice and do it, and sometimes not do it well and be able to reflect on what it could have done better.
Right. Okay. So in the interest of our time, there are two key questions that I must ask you before we get to the end of our show. First question is, what is the hardest aspect for you personally of your job or your role? You personally.
For me personally, it's dealing with the fact that I have a very significant chronic illness on top of the fact that I'm a chief medical officer. And that's me personally. That is not going to affect many other people. However, everybody has something that's not part of work that will impact their work, whether it's a family issue, a personal issue, whatever. So that is something that probably nobody other than my spouse, and now you know that it affects everything that I do every day. So,
well, again, thank you for sharing. My audience may know this because I have been public about it only in the last few years. I too have had a chronic illness. I was diagnosed in medical school with Crohn's disease, and I made a decision with my father that we would just push on. We had no idea what we're talking about because I could have chosen an entirely different life path. And so thank you for sharing. I fully understand. And I think the point is not MS or Crohn's. The point is everybody comes to the table with a whole backpack that they left at the door or left in the car when they walk into their office. And I think it behooves leaders to be respectful and mindful and have an awareness that, you haven't walked in their shoes. So be compassionate, be curious. And you've already stated that. Okay. Next big question.
Yep.
What do you think is the biggest fire in healthcare today, in your opinion right now? And what can a chief medical officer do about that, if anything?
Wow. So, honestly, I think the biggest fire is in healthcare today, and I look at it as an entire industry, is really understanding the finances. We're on a catastrophic course around the cost of healthcare in the United States. And we, as clinicians, need to be able to take really great care of patients, but it is beyond the time where we can't think about the financial impact of everything that we do. Now, I remember when I went through my training, we didn't know how much a lab test cost. We didn't know how much a CT cost. And we almost took pride in that. I'm going to do the right thing for the patient, and the cost is irrelevant. And those days are gone, and they have to be gone. And so for clinicians in leadership roles or anybody in the medical staff, I'm not saying that it should overpower all of your clinical decisions, but it needs to be part of them while you're at it. Is this test going to actually influence the outcome or the treatment plan, or am I just doing it for academic purposes? If that's the case, then maybe you can skip a day of your CBC. Or maybe you don't need that chest X-ray every single morning. I'm, thinking in the hospital setting. But those are things that are important for us to understand and acknowledge, and it feels distasteful, yet it is the reality of the world. And so, healthcare organizations, independent healthcare organizations like mine, we're nonprofit organizations, and so for us to lose money, what they say is no margin, no mission. You've heard it before. If we're not conscious of the economics of what we do every day, then we're setting ourselves up for long-term failure, even though we may be taking really great care of this patient right now. And so I think that that's important for us to think about. And when we start talking about utilization review and utilization management and length of stay, understanding how all of those impact the bottom line of the organization. It's been imposed on us. It's not something that we ever asked for as clinicians. Nonetheless, we have to deal with it. And so I think that's the biggest dumpster fire that we face as healthcare right now. And I think that's nationally. That's not my organization. That's not yours. That is nationally. And then, again, I'm involved in legislation. Every time I look at another piece of legislation, I look at how does that make it worse, actually, rather than better. Cuts in Medicare spending, cuts in reimbursement patterns, all of those affect us negatively on the bottom line.
Yes, and the phrase that came out through the New England Journal of Medicine in an editorial is the financialization of medicine.
Yeah.
The financialization of the work that surrounds the care of other people is no longer something that people can ignore, including physicians. And I think the medical students of the future, not tomorrow, not our admission cycle today, but in the future, we're going to have to look for people whose motivations include rising into leadership, understanding the environment like never before, including an aptitude and an appetite for getting their arms around the financial constraints in order to set other people up who maybe simply just want to have a salary, like you said, and they won't over-order that chest X-ray, but they're going to enjoy taking care of that patient because that's what motivates them. So, we've only got a couple minutes here, so and I know you have an important meeting at the top of the hour. So let me just wrap up by suggesting, of course, that being a chief medical officer is no small task, and it takes intentional preparation, and oftentimes can feel like a trial by fire. And it was my old boss who told me that it is very similar to a career in firefighting. You start out, you go to firefighting school, you do a lot of training, you drill, and then someone says you're ready to fight a fire, and you put on the uniform, you put on the helmet, and out you go. And then one day someone taps you on the shoulder and says, hey, would you like to be the squad leader? You did a great job, or the captain. And then perhaps they tap you on the shoulder and say, we want you to become the fire chief of the house. And my boss always told me you cannot be a good fire chief without first becoming a firefighter. Would you agree with that?
I would agree. I like that analogy. And, I come from a military background, and every level you're getting promoted and you're becoming a higher level leader. But every one of those comes with learning, experiencing, learning at a different level, experiencing, learning at a higher level, and you keep this iterative pattern alive. And I think that it's very similar to what you are speaking about. And I believe that the same type of approach is appropriate in medicine and leadership development.
Lifelong learning. And it's a marathon. It is not a sprint. It was a pleasure to have you on the show, Bob.
Yeah,
you've been listening to the Fire Chief Podcast, the only podcast dedicated to the CMO. Want to learn more about what it is like to be a CMO? Want to be on the show? Email me at leescheinbart@gmail.com or connect with me on LinkedIn. You can listen to the podcast on Apple, and you can also watch the videos of the shows on YouTube. Our show's website is thefirechief.podbean.com. I love talking with CMOs from all over the United States, so please connect with me, leave your reviews and your comments, and please share this with your colleagues. And in the words of Sergeant Phil Esterhaus, let's be careful out